Hello and welcome to the Osteoarthritis Action Alliance Lunch and Learn webinar for August 20th, 2025. Thank you for joining us today. And thank you to the current Osteoarthritis Action Alliance sponsors who support our work, which includes the monthly Lunch and Learn series. Now it is my pleasure to introduce today's speaker, Dr. Grace Lowe. Dr. Lowe is a clinical researcher with a focus on osteoarthritis since 2001. She is an associate professor at the Baylor College of Medicine. She received her rheumatology training at Boston University, where she also obtained a Master's of Science in Epidemiology. She's been working with investigators of the Osteoarthritis Initiative, a cohort of people who are either at high risk for or already have symptomatic radiographic knee osteoarthritis at the time of enrollment, and she has spent much of her research conducting studies using data that has come from this cohort. With the administration of a lifetime leisure physical activity survey, she has been particularly interested in the associations of these exposures to knee osteoarthritis outcomes. The title of today's presentation is Associations of Bicycling and Walking in Knee Osteoarthritis Prevalence and Progression, Possible Implications for Osteoarthritis Prevention and Management. Welcome, Dr. Lowe.
Thank you, Katie, and thank you to the OA Action Alliance for inviting me to come and participate in this webinar. So reasons to look at the relationship between physical activity and knee osteoarthritis include that physical activity is a non-pharmacologic intervention, oftentimes with a low price tag attached that is potentially durable. If found to be beneficial, it'd be a huge step from a public health perspective to encourage these particular activities to reduce symptoms. If an activity is harmful, then it would be useful to understand risks from participating in the activity, and there might be strategies to mitigate the risk or to avoid the activity altogether. So when we look at the guidelines on the management of osteoarthritis, looking at these different organizations, these are the ones that I reviewed from ORSI, from the ACR, and from EULAR. Generally, the recommendations are very similar in terms of providing strong recommendations for exercise programs, but the recommendations kind of lump everything together, looking at strengthening, cardio, balance, and that sort of thing. And I'm saying that there's a lot of data to support that, largely from this Cochrane review that was done by Franson et al., that included 44 different studies looking at the outcomes of pain, physical function, and quality of life. And they reported that there were benefits in all these domains, and the quality of the evidence was between moderate to high. So there's good reason why these recommendations exist in these guidelines, but I do think that there is a potential that different activities might provide different benefits or harms. So first I wanted to look at walking in exercise for people with knee osteoarthritis. And so this study is one of the seminal studies that really provides evidence for walking in osteoarthritis. And it was published in JAMA in 1997 with Edinger as the lead author. So this figure is the main figure to the study. And on the x-axis is the months of observation. So there was a time point where there was a more intensive face-to-face interaction, and then there was a time period where they transitioned to a self-driven participation in these activities. But the observation was over 18 months. And on the y-axis was the summary disability score, with a higher score representing worse disability. So in total, there were 439 participants in the study. And in the health education arm, which was the control arm, over this 18-month period, they saw a worsening of the disability score. Whereas for the exercise and walking program in this green arm, they saw a substantial improvement in the disability score over that 3-month period where it was face-to-face. And then when they transitioned to a self-driven program, the the disability score was a little bit worse, but it never got to a point where it was worse than where they started. And then when you look at other secondary outcomes that they had, including their performance measures of a 6-minute walk, the walking was better in the walking arm, which I would expect it to be since it was a walking intervention compared to the education. And then when you look at other tasks, they also saw a benefit in the walking arm. And this included stair climbing as well as lifting and carrying items. And then there was a task of getting in and out of a car. Importantly, also, the disease activity was evaluated. And so this included a pain intensity score that was graded between 1 and 6, and 6 was a worse amount of pain. And those in the walking arm had a lower amount of pain compared to the health education arm. They also looked at radiographic scores, and what they found is that there was no difference in the arms, and that may not be surprising, but that is nice that they did take a look at that. And then when they looked at fitness measures, they also saw that the knee flexion strength was better in the walking arm, which is also nice to see that there are so many benefits to walking in this randomized control trial. So our group also looked at the association of walking for exercise in as it relates to symptoms and structural progression in people with existing knee osteoarthritis, using data from the Osteoarthritis Initiative. And so we published this in Arthritis and Rheumatology in 22. So why were we interested in looking at this question? So the OAI is the largest cohort of participants that we're aware of that has information about people's walking habits and prospectively ascertained standardized measurements of osteoarthritis symptoms and structure. So this is our main table that we present in this study. And I really think this first row is kind of the most exciting and interesting portion of our findings. So we identified people who were walkers or non-walkers based on a questionnaire that we sent out to the participants. And when we looked at people who did not have frequent knee pain at their baseline visit, and then we looked over a 48-month period to see who would develop frequent knee pain, amongst the people who were non-walkers, 37% developed the outcome, as opposed to amongst those who were walkers, only 26% developed the outcome measure of new frequent knee pain. And so this resulted in an unadjusted odds ratio of 0.6, which was statistically significant and pretty much unchanged when we adjusted for age and sex. And so I think this is the most exciting because this sort of gives this idea that when people have radiographic evidence of disease and don't have symptoms yet, that something that they're doing might actually change their outcome in regards to symptoms. And I think this is really pretty exciting. Then we looked at structure, including Kellgren and Lawrence grade, which I think most people on this webinar might be aware of. But Kellgren and Lawrence grade is a score between 0 and 4, looking at overall radiographic severity of disease from the radiograph. And so when we looked at people who were non-walkers and walkers, really the amount of worsening was about the same, 21% versus 18%, and this did not result in a statistically significant difference. Then we wanted to look at the medial joint space narrowing, whether or not it got worse over this 4-year period, because most of the load within the knee occurs in the medial compartment. So we really felt like this was a compartment within the knee that was potentially at risk if they were walking. And instead of finding that people who walked actually had more medial joint space narrowing over time, actually they had less. And so this was actually very reassuring and also encouraging in terms of the fact that 27% of people who were non-walkers had the worsening, whereas the walkers only 22% did. So this resulted in an odds ratio of 0.7 that just met statistical significance, and the adjusted odds ratio was similar, though a little bit higher with the adjustment. So I think that was actually also very important and encouraging. So this last row is actually my, I would call the most disappointing part of the findings, although I think if you look at it from a glass half full perspective, there's still benefits to what we can see in this row. But I think this outcome is most relevant to what we normally see in the clinical setting. So as a rheumatologist, I see people in clinic and they come to me complaining of knee pain. And then you get an x-ray and you see that they have radiographic evidence of disease and they have the knee pain, and you tell them, hey, go walk. And so what I wanted to see here is I wanted to see that when I tell people to go walk, that they would in fact have resolution of their frequent knee pain. But in fact, we actually don't see that. People who walked and didn't walk actually did about the same. And so it's discouraging in the way that I was sort of expecting there to be a particular finding and it wasn't there. But at the same time, people who walked also didn't do worse than people who didn't walk. Where like it's not like we saw that there were fewer people who were walkers who uh, had improvement of the frequent knee pain. So I don't think it's harmful anyway amongst people who have frequent knee pain at the outset. And I think this is important for people who have other comorbidities, which is very common amongst people who have knee osteoarthritis, in terms of other comorbidities like diabetes or cardiovascular disease or hypertension, where we know that doing physical activity can be beneficial for them. And so we don't want their knee osteoarthritis to deter them from participating in the activities that then may provide them with benefits for other reasons. So the take home from our study, I feel like, is that prevention really may be the key. Targeting people with radiographic evidence of osteoarthritis without frequent knee pain might be an important time to intervene. So perhaps we should consider a paradigm shift. I think that there might be a good reason to screen people with x-rays to identify people with osteoarthritis that do not actually have frequent knee pain and encourage walking in those people. Of course, I'm just suggesting this as a possibility. We haven't done any kind of study to actually show that this is beneficial, but I do think that this would be a huge paradigm shift, because what we do now in the clinical setting is that, like, even if somebody has radiographic evidence of OA, we don't get radiographs regularly. We only get them to, confirm a diagnosis and if something's not really acting right. In people who are of a certain age who would be at risk for knee osteoarthritis, there's no screening that occurs for those people. So this would really be a change in the way that we would be approaching the condition. So the other conclusion is that walking amongst those with baseline knee pain did not lead to improvement, but it also did not lead to worsening. So I think this is reassuring for the reasons that I mentioned before, that people do have other comorbidities. And so if they can benefit from walking for those other conditions, it doesn't hurt them from an osteoarthritis perspective. So I wanted to mention this other study that was also presented at ORSI this past year that looked at walking with incident knee osteoarthritis. So they used data from the UK Biobank, and they identified this metric called purposeful walking steps. And what they found is that the adjusted hazard ratio for incident symptomatic knee osteoarthritis was less as people walked more. So this was data that was ascertained using accelerometry data. So I think this provides additional data to support the benefits of walking in osteoarthritis. So I just wanted to take a minute to talk about resources that can encourage walking. So I bet if we look around our virtual room and we look to see how many people have a smartwatch, we'll see that a lot of people are wearing them, including me. I have an Apple Watch, but there are lots of devices out there, including Fitbits and Garmin watches and that sort of thing. Walking clubs can be very helpful. This can be through a gym or work, healthcare insurances, schools, social media. The sort of opportunities are endless. And then I just wanted to take a moment to talk about the Walk with Ease program. So this is a community-based physical activity and self-management education program where walking is the central activity. It's a multi-component program that also includes health education, stretching, strengthening, and motivational strategies. The program also comes with a guidebook and a walking schedule. And it's offered in two forms. One is a self-guided course, and the other one is a community-based course. Um, so, um, okay, so of course, this is created and managed by the OA Action Alliance, which is also sponsoring this talk today. So I thought it was a little apropos to go ahead and include it in. Lee Callahan kindly shared these slides with me a few years ago, actually, but I think they're actually still current. I just recently logged in to check to see that things still look similar, and I think they do. So for those who are interested, the portal can be accessed using this URL, start walk with ease. Got to do the exact correct URL. startwalkwithease.org. And this can lead you into a way to get signed up, and then you can see this, all these resources that are available through the portal, including this ability to create a walking schedule that is then customized to you, which I think is very helpful in terms of encouraging people to create attainable goals. So I just want to take a minute to show that there is good data to show that this intervention is actually beneficial. And so this is published in Arthritis Care and Research from 2011. And this just took the data that was out there. So people who participated in the study, in the intervention in Walk with Ease, and looked to see how they did. And so when they looked at the HAC, which is a disability score, they found that at the 6-week follow-up, that both the people in the self-directed format and the group format did well. They had improvement of their disability. But interestingly, the people who did the self-directed format had a more durable benefit at the 1-year follow-up. And I think this is really interesting because I think the concept that if we can teach people to do an activity and to create a habit, that there's a greater chance for a durable benefit. And I think this is what these findings are suggesting. And when they looked at other outcome measures, including arthritis symptoms, they found a similar arrangement where the benefit was seen for both the self-directed format and the group format at the 6-week follow-up, but the 1-year follow-up only showed benefit in the self-directed group. And same for fatigue, which I think is pretty amazing. So that's just a plug to say that the Walk with Ease is an excellent resource, and I think that it should be considered as a way to encourage people to walk. So I just want to take a little pivot and talk about bicycling. This is a paper that we published last year. And I think that the findings from this study are also very exciting. So what we did was we looked at all of the people within the osteoarthritis who completed our questionnaire about leisure physical activity. And in total, we had 2,607 people who responded. And in total, 52% of people, which represented 1,344 people, had reported bicycling at some time in their lives. And I think that's like a pretty impressive number that more than half of the people had done some bicycling in their life. So this is obviously an activity that people participate in a lot. So when you look at the outcome measure of frequent knee pain, we found that people who had bicycled any time in their life had a lower risk of having frequent knee pain at the time of observation that we're looking at, compared to people who are non-bicyclers. And so this resulted in an unadjusted odds ratio of 0.83. And when we adjusted for age and gender, this remained pretty much the same. And then when we looked at radiographic evidence of disease, we saw a similar finding where there was a lower percentage of the outcome measure amongst people who were bicyclers compared to non-bicyclers. And then we saw something similar amongst when we're looking at symptomatic OA, which means that they had to have the combination of radiographic evidence of disease and frequent knee pain in the same knee. And we saw this finding present for all these outcomes. So the thing that was a little surprising, though, is that we didn't really see a dose response when we just looked at the number of times that people participated in the activity and broke it down. It was actually just like overall, there seemed like there was a benefit. So we wondered why that might be. And so we looked at the pattern of participation in bicycling that people did during in this study. And I thought this was really interesting, but not surprising, really, that amongst the people who did bicycling, that the most common arrangement was that people bicycled between ages 12 to 18, and that this represented 30% of the people who reported that they were bicyclers. The next most common arrangement is that people bicycled all four age ranges between ages 12 to 18, 19 to 34, 35 to 49, and then ages 50 and older. And then the next most common was that people just bicycled age 50 and older. So, I didn't really think that the people in this group and the people in this group really were the same. So we decided to do a different analysis to look to see if the number of periods of time that people participated in the activity would show a dose response. So we looked at those different age ranges that I just mentioned, and every time that people reported that they were bicycler, they were given like one time period credit, I guess. And so when we looked at the outcome measure of frequent knee pain, what we saw is this very strong dose response. So the more number of times that people participated in bicycling, the lower the outcome. And it was very dramatic and very consistent. Unadjusted and adjusted risk ratios were statistically significant. The P for trend was statistically significant. And then when we looked at radiographic evidence of OA, same thing, like really robust findings. And then also when we looked at symptomatic radiographic OA, very clear dose response to these findings. So I just want to take another minute to talk about like, hey, what about those people who only bicycled ages 12 to 18? Does it actually matter? And what I would say that the findings that we saw in our observational study was that it looks like it really kind of does, right? So I only presented here the results related to the symptomatic radiographic OA, but it's really the same for just the frequent knee pain and the radiographic evidence of OA, that even if people just bicycled this time frame from 12 to 18, we saw a lower odds of having the outcomes of interest. So it really suggests this idea that if you participate in this behavior, even at this young age range, that you might develop or you might have a benefit to it at a later time in life. So what do we sort of glean from this study? So I say that those who participated in bicycling had a lower prevalence of frequent knee pain, radiographic evidence of OA, and symptomatic OA. The benefit was cumulative if people participated in the activity during more age periods, that there was a greater benefit. The most common period that people bicycled was at the youngest age range, and just participating in that age range is also associated with better knee health. So I think this study supports the view that bicycling may be favorable to knee health overall. So what's my sort of takeaway from like all the things that I've talked about today? So one of the important takeaways is that I do think that prevention is really critical, and that we should really consider a paradigm shift, that targeting people with radiographic evidence of disease without frequent knee pain might be a really important time to intervene. And that if we use this idea and screen people with x-rays to identify people with OA without radiographic evidence, with radiographic evidence of OA, but without knee pain, that this may be a really nice time to intervene. And this could be a time that we could encourage people to walk, and maybe other interventions may be beneficial at that time as well. I think bicycling also offers something even more because not only does it look like it's beneficial amongst the people, like later in life, but also very early, like when people are very young and they're participating in the activity, it seems like they derive benefit even like when they're in their 60s. So I take this timeline from the CDC website, and I just want to sort of apply it to osteoarthritis. So um, I liked sort of the concept that this is just a generic idea of how to think about the natural history of disease and to look at it in terms of osteoarthritis. So um, this stage here, the stage of subclinical disease, is what I would consider early osteoarthritis. And so the thing that classifies people as having subclinical disease or early OA is that they have evidence of pathologic changes, but it should be before the onset of symptoms. This is what I consider established disease or the stage of clinical disease. And so this is really like when people come to clinic, right? And so I think this is like an important time that we can intervene. So there's also a stage before people have pathologic changes. So it's a stage of susceptibility before they get to any of the pathologic changes. And so I'm advocating that I think bicycling should be recommended like this whole period of time. I mean, I can't say that I have a clinical trial that definitely supports it, but I do think our observational study provides good evidence that this may be the case. And I think walking is beneficial from this period. I'm not saying you shouldn't walk at all this period, but I think that from the perspective of information that we have that shows that walking is beneficial from an OA perspective, if we can identify people who have pathologic changes but don't have symptoms yet, that this may be the time that can be really beneficial to encourage walking for this group of people. So that's the end of my talk, and I wanted to thank everybody for listening, and I'm open to any questions.
Thank you so much, Dr. Lowe. That was really interesting. And we're going to squeeze in a couple of questions here. One in the chat, which came up for me as well when you were speaking about bicycling. Did it matter if people were on a stationary bike or versus biking outside?
That's a good question. So the way that we administered the question, we said either or. So I don't actually have that information, but we did ask people if they, rode on a stationary bike or rode outside. So I don't know, but it's a good question. And I think that there are so many different varieties of bicycles now. It's important to know that, this cohort of people were they're like in their 80s now, and so the time that they were bicycling was like in the 1960s, so I would guess that most of them, in their younger ages, particularly, probably had very low tech in their bicycles, and when they did their bicycling at their later age ranges, there might be more stationary bicycling, but I don't know that for sure.
Thank you. Just a comment here from someone who says, anecdotally, I see people, especially men, take up cycling in later life because of knee pain while running. So it was interesting and seems to fit the cycling more periods of time, reduce the risk of symptomatic OA and early cycling. So just an interesting point. And then follow-up question, how would it work to screen people without knee pain to see if they have radiographic evidence? Would it just be age-based, like feasibility-wise?
I think it would be. I mean, I think in the same way that we screen people for osteoporosis with a DEXA scan, we could screen people with a radiograph. Like, so I would guess, I'm spitballing here a little bit, but, starting age 50 or 40, start to just get an x-ray when you go to your primary care doctor. In the same way that we also, check your blood pressure, see if it's elevated, check your cholesterol, see if anything is elevated, do a risk analysis, to see if you would benefit from any preventative strategies. Kind of similar here. So that's kind of what I'm envisioning. Although I don't know that there has been uptake yet, but I like that concept of it. And I think the idea that we need to shift when we are focusing on intervening for osteoarthritis from a later state to an earlier state. I'm not alone. I'm not the one who started that trend, but I think within the osteoarthritis research community, there's this very intense effort to move the needle towards the left so that we can understand how we can help in that time period more, because I think that's actually the time period that we can actually make a difference. I think there's been so much time and resources spent on people with later disease, and we've been so unsuccessful at finding effective treatments in that group. I think it makes the most sense to sort of move towards this direction.
Thank you, Dr. Lowe. And if you have time, I might just try to fit in one more question.
Sure.
I'm curious for you and your team what you see as the future directions for looking at physical activity as it relates to preventing and managing OA.
Well, thank you for that question. I mean, so we have put this questionnaire into the Osteoarthritis Initiative, and it's been a really wonderful opportunity for us to look at very specific different activities and to think of them in different ways and not to just lump all the activities together. So I think that really going through and understanding how the different activities relate to the different outcomes in osteoarthritis is really important for us to understand. And then I think any kind of findings that we see based on that, it's important to do clinical trials to evaluate whether or not our observations in the Osteoarthritis Initiative and in other cohorts would then be replicated in that setting. So I think that that's what I envision.
That's great. Thank you. So more to come.
Yes.
Great. Well, I'm going to launch a quick poll. Hope everybody can take a look at those questions before you leave. And Dr. Lowe, thank you so much for your presentation today. It was really great. We really enjoyed having you today. And thank you so much to the audience for joining the presentation. Hope you can sign up for next month's Lunch and Learn, which will be on September 17th. And I will drop that information in the chat. The title will be Food as Medicine for Osteoarthritis, Practical Tips, Research Spotlights, and What the Future Holds. Thank you, everyone, and that concludes today's presentation.